I would like to show you how AnyLogic has helped me and my colleagues to address a very thorny issue in U.S. healthcare policy. And that is, how do we bring down the rate of cesarean delivery for childbirth? This morning, I'm going to cover 4 areas. First, I want to give you a little background about why this is an important question. Actually, it's probably important for many of you too, as you'll see, even around the world. Then, I'd like to describe for you what the challenge behind this question is, what was difficult for us in addressing this question. Then I want to talk about a model that we've developed called the Cesarean Delivery Model. This is an AnyLogic agent-based model, and it's really at the heart of our approach to this problem, and it's a brand new approach to the problem. And finally, I'd like to tell you what some of our results have been to date. So I would encourage you, a little differently from the other presentations, if you would, I like questions, and I love people when they don't understand what I'm saying to sort of put me back on track. So I know what I'm going to present may not be everyone's shop, but if I say something that's not clear, confusing, if you have questions, please interrupt. I'm going to try to make plenty of time that we can answer questions. So first of all, a little background. There are 2 types mainly of childbirth. One is vaginal delivery, which is the natural way that we've delivered children for a very long time. And the other is called cesarean delivery. And this is a very intensive abdominal surgery where the obstetrician cuts through the abdomen of the woman, cuts through the uterus, and brings the baby out. And if you're wondering, by the way, the woman on the left is extremely happy. This is the way my wife and I delivered our children at home, pretty much like that. So I can vouch for how she's feeling right now. Cesarean delivery has many problems that come along with it. One is it's major abdominal surgery, so you have risks of infections, blood clots. Many women have hysterectomies directly as a result of this during the operation. But very importantly also, cesarean delivery, when you cut through the abdomen and bring out the baby that way, has pretty deleterious effects on the mother and child from a psychological standpoint. There's much worse bonding, much less satisfaction. Children don't tend to develop as well after cesarean delivery. Some of the children develop pulmonary disorders, asphyxia and respiratory distress syndrome are 2 of the main ones. Breastfeeding is compromised. Later births are compromised because think about it, you're cutting through the abdomen, you're going to have scar tissue, which is going to make later births much more difficult. It increases the morbidity and mortality of both mother and child around the childbirth, and the cost is much greater. So what I'm wanting to get at here is this is a big deal. You know, it's very expensive, and it's really putting at risk mother and child. So you would think that because it's such a big deal that around the world we'd be paying great attention to it and keeping the cesarean delivery rates as low as possible. Well, unfortunately, that's just not so. The World Health Organization a few years ago came out with a document that said, it seems to us that a reasonable cesarean delivery rate would be somewhere in the area of 10 to 15%. And that's the green here in the spectrum of colors. As you can see, in the developed world, there's very little green. As a matter of fact, very interestingly, in Europe and the Americas, the only green is in the Netherlands, and we'll get back to that a little bit, why the Netherlands is green. But there's a lot of red, a lot of orange. In the US, same thing, lots of deep oranges. So we have cesarean delivery rates that range from a low in Utah of about 20% to many states, especially in the South, that go north of 40%. Many hospitals in the US are delivering children by cesarean cesarean delivery at rates of over 50%. That is, in many hospitals in the US, if you go into that hospital to have a child, chances are 50-50 you're going to have major abdominal surgery. So I and many of my colleagues think that this has to change. But when we look at the history of cesarean section rates, back in the 50s and 60s in the US, we had very low, and this is true around the world, the cesarean rates were very low. And this is not because our technology was so poor that we couldn't birth babies. It was just low. Actually, I think that our ability to birth babies was actually better then than it is now. But it was fairly low, around 4.5%. Over 50 years, that has risen to, on average, in the US, 32.7%. That is, out of every 3 babies born in the US, 1 of them is going to be born through cesarean delivery. Question? From a woman, yes.
We'll make Renee work. What percentage of that is planned cesarean versus going into the hospital already in labor?
There are a few answers to that. If you mean how many of that is preterm, so you've got women who go in preterm and they think that they need to have a cesarean, it's fairly low percentage. If your question is, however, what percentage of that is women who want to have, who because of scheduling reasons or for whatever reasons, fear or whatever, they really want to have a cesarean delivery? Actually, that percentage is also very low. And that surprised me when I was doing the research. Women don't want, in the main, women do not want a cesarean delivery. So they do not plan these. And also obstetricians in the US, especially Brazil, this is different. Obstetricians don't plan cesarean delivery. So the percentage is fairly small. I don't remember the exact percent, but fairly small. Thanks for the question. So what about the cost of cesarean deliveries? Is that meaningful? Turns out it is. Of people going into hospitals age 65 and lower, childbirth is the second most expensive condition bringing you into a hospital. Every year we spend about $30 billion in the US on childbirth, and about half of that is on cesarean delivery. Now, about half of that is unnecessary cesarean delivery. So if you think about it, that equates out to maybe $2, $3, $4 billion a year that we're spending that we do not need to spend, because having a baby by cesarean delivery is far more expensive than having it by vaginal delivery. So $2, $3, $4 billion a year that we could save. When you look at it in the big picture of US overall healthcare expenditures, which are $2 or $3 trillion, it probably doesn't seem like much, but you know, $1 billion here and $1 billion there, pretty soon it adds up. So what's the challenge here? Well, obviously, the challenge is we need to reduce these rates. But I'm not the first one to recognize this challenge. It's been recognized for over 50 years, and many people have addressed this challenge. Very significant books have been written about it, elucidating the problem, giving suggested solutions to the problem. Literally hundreds of researchers have researched this to death, using every type of research methodology, very good structured studies, and the consensus is this really needs to change. It's really a problem. Organizations like the College of Obstetricians and Gynecologists in the US have come out and said this has to change. The World Health Organization has come out and says this has to change. The US CDC has come out, this has to change. Well, we've been doing this for 50-odd years now. It's not changing. It's getting worse, actually. The rates continue to go up. So what are we going to do? I and my colleagues are taking a slightly different approach. First of all, we're going to address this problem at the state level because this is every state is the birthing environment of every state is very different. You have different types of hospitals. You have Medicaid, which is a state-by-state run funding agency, very different from one state to another. You have very different networks of physicians working one state to another. So we're focusing on it from state to state, and we're beginning with 4 states. Washington State, where I am from, I'm very familiar with the environment there, Illinois, New York, and West Virginia. We're including West Virginia because, as you may or may not have noticed, West Virginia has one of the highest rates of cesarean delivery, and we wanted a broad spread over the United States. So we're beginning with states, state by state. Second of all, we have learned from looking at the research that it's critical to bring together coalitions of stakeholders in order to solve big, complex problems like this. You cannot attack it from one perspective. You have to bring together all perspectives. So we're bringing together a coalition of major stakeholders, including legislators, health agencies within the states, health insurers, typically all big health insurers within the states, Medicaid, hospitals, clinicians, and not just obstetricians, but certified midwives and licensed midwives, because they're the ones who actually make the Netherlands work. The Netherlands actually defer all of their births first through midwives. Then if there's a problem, it goes to obstetricians. So certified midwives, licensed midwives, very critical to this problem. And of course, women. Third, and most uniquely, what we're going to do, or what we're doing, is using AnyLogic as a health policy lab. And by that I mean, we're using AnyLogic as a platform for all of these stakeholders to gather round and begin to ask questions, what if we implement this initiative, this health policy change? What will happen? Well, instead of having policyholders come in with their pet initiative of the month and want to try to push that through for political reasons or whatever, we're going to force them to show how an initiative will actually play out through the behaviors of these agents. They're going to have to show us with research, if you do implement behavior X, what is the impact going to be on all of these actors within the environment, and what do you see the end point being? They'll have to show us step by step by step. And that's one of the major virtues of agent-based modeling. As you know, you have to look at it agent by agent, step by step by step. So we're going to use AnyLogic we're using AnyLogic as a health policy lab, and also as a simulation-based learning environment. Now, what do I mean by that? That term actually comes from Gary Hirsch, a researcher in Boston, who did research in making healthcare decisions primarily in Illinois. And he discovered that bringing stakeholders together in a room like this, putting them at different tables, playing games related to the policy decision, makes them start to speak the same language and makes the decisions that they come up with much more robust and makes them actually implementable. So simulation-based learning environment is a long way of saying we're going to play games with the stakeholders. They're going to come in and we're going to put the legislators in the shoes of the health insurers and the health insurers in the shoes of the women and have them play the different roles of these agents using AnyLogic to come up with innovations in health policy initiatives. So a three-pronged approach. You might ask, okay, well, why would you choose agent-based modeling? Clearly, AnyLogic has other types of modeling, system dynamics. Why wouldn't you choose system dynamics? Well, here are the reasons. First of all, there are many heterogeneous agents that are at play in this policy area. You've got thousands of women in Washington State. You've got 7,000 births a month, so thousands of women. You've got hundreds of obstetricians and certified midwives. You've got dozens of hospitals. You've got many health insurers, so many agents, many that are heterogeneous and are making decisions independently one from another. Space is also very important in this decision. If you think about it, how does a woman decide which obstetrician to choose or which midwife or which doula? Usually it's someone close to them, right? And which hospital does an obstetrician go to? Usually it's a hospital nearby. So space is very important. So the GIS capabilities of AnyLogic play a major role here. Next, network effects. Obstetricians, we know from research, they make many of their decisions based on what their friends' colleagues do. Same thing with women. They make their decisions about who they select for an obstetrician often based on what their friends do. So networks are really important. Feedback is really important. So having very robust behavior capabilities in AnyLogic is very important because obstetricians learn from what happened before. If they were sued last month because they did X, then they probably won't do X again. So feedback's very important. And lastly, AnyLogic and agent-based modeling give, as I mentioned before, a cogent bottom-up way of modeling these problems so that you have to be very explicit about your assumptions in reaching a policy decision. And that's, that explicitity is something that's been missing a lot in US healthcare policy. Much of our policy gets made sort of on the fly, off the cuff, but agent-based modeling really makes you focus and be very explicit about your assumptions. Why are we choosing AnyLogic? Well, I've worked with, I think, most of the main agent-based modeling software platforms, and I find that AnyLogic has a very sophisticated agent-based modeling capability. It's scalable for many agents, and here we're using, you know, there are 100,000 women every year in these states who are having births, and AnyLogic scales very well to that number of agents. The GIS visualization in AnyLogic is good, and now it's really good. The state charts and flow diagrams in AnyLogic make it very visual for stakeholders to understand what's happening with behavior among the agents. AnyLogic has very sophisticated message passing capability, and as you'll see in a minute, this is really important. It interfaces very well with Excel, and Excel is used by most health insurers and state agencies for doing analytics and passing data. And of course, they're very robust experiment types. So you can try different parameter sets, and you can compare different runs and so on. And Diana, there's very good optimization in AnyLogic, and that's something that I'm going to be addressing very soon in these models. So let me tell you a little now about the model that we've put together. First of all, it includes these agents, women, obstetricians, certified nurse midwives, licensed midwives, hospitals, health insurers, and Medicaid. What we've done is for each state to actually use the agents that are there. So we've not done any abbreviations, there's no averaging, it's actually using the agents that are present in the state. There's a wrinkle here, though. As you probably know, in healthcare in the US and elsewhere, health data is very sensitive. And so we had to be very careful about the data that we're using, especially for women and the clinicians, to hide it so that someone using the model can't go back and find that woman or that obstetrician. So we've had to develop synthetic data from the original data in the States. And we have a couple of Excel data sheets that develop the synthetic data and make that easy for the states will actually do this, and the analysts in the states. So we have a couple of spreadsheets allowing them to do that. And then we use actual data for hospitals and insurers, which the states will also develop. And we will feed that into the Cesarean Delivery Model. Very important in our model is to model the key behaviors of all the agents within the model. Because if you think about it, it's the behaviors that really count. It's how an obstetrician makes the decision whether or not to have a cesarean delivery that really makes the difference. So we're modeling behaviors very carefully. And I'm just going to flip through here to just show sort of the order of the behaviors that we're modeling and say a little bit about them. So first of all, the women, they have to choose their primary caregiver for having the birth. And the clinicians have to choose the hospitals they're associated with. Once the birth starts happening, it may happen that the midwives have to refer the patient, the mother, to an obstetrician for a cesarean. So they have to choose the obstetricians for a referral. And finally, when it comes time for the birth, the woman has to communicate with the obstetricians. You know, I'm in labor, it's time to have a birth. And all of this is done by message passing within AnyLogic. So the mothers actually pass messages to the obstetricians. If there are referrals, the midwives pass messages to the obstetricians. Once the birth has happened, the clinicians pass these messages to hospitals and to the women, actually letting them know what kind of birth they had. And then you've got payment. You've got claims that are submitted to the insurance companies, and you've got payment going back. So lots of behaviors happening in this model. And they're very robust behaviors. Just to tell you how we're handling behavior, because I thought this might interest you, is in research that I did for the Society of Actuaries, I developed a template based on work from Peter Osorio at the University of Colorado. And this template is a special template that we're using for all behaviors within the model. It has 10 main components that you'll see there. And to give an example, here is when a woman chooses a primary birth attendant. This is how she would use each of those components. She would use some data. She would have this number 8 is her produce output is she's getting the identifier of the nearest birth attendant, and then she's choosing that birth attendant. She's sending output actually back to herself for her attribute. So this is just showing that for this behavior and for much more complex behaviors, we're using one behavior template. Here's a much more involved behavior. This is how obstetricians decide the delivery method. But again, even for very involved methods, we're using the one template. For message passing, we're using the send function in AnyLogic, and we're using their standard connections link. And the message class is very simple, as you see here, just a few items in that class. And for visualization, we're using these symbols to represent the agents within the model. The women are circles, and the gold is vaginal delivery, the blue is cesarean that's appropriate, the red is a cesarean that you really didn't need to have, and obstetricians are squares, and so on. This is actually a visualization from the model. This is a month in Washington State, and it's showing all the deliveries within that month. It shows how they are, whether they're vaginal or cesarean or not. It's showing in red the hospitals that are over a threshold for what's appropriate cesarean delivery. And as you can see, this is fairly complex, a lot of data on one chart. So what the model does is it allows you in this area 1 here to have check marks to turn on and off things in the model. So for example, in this model, everything's turned off except obstetricians and women who are having cesarean deliveries that are inappropriate. So it allows you to sort of zoom in on what you want to see. Also, if you click any agent in the model, it allows you to see details about that agent, which is area number 2. And area number 3, you can pan, you can zoom. And for example, suppose some user wants to zoom in on a particular county, like here. They can zoom right in, and it will show the networks of the women to the obstetricians, to their caregivers. And a user of this might wonder, well, why are women traveling 20 or 30 miles to see a caregiver when they're right next to a hospital that they're not using? So it brings up all sorts of interesting questions. User interface, we have 2 areas. One is for data, simulation and data-specific things on the left, number 1, and then on the right are the parameters that the users can enter to play these games, to play the simulation games. And here's some examples of what the parameters look like. For example, nearly all the agents have motivations. The clinicians have geographic distributions and so on. So as you're playing the game, you would enter these various parameters. You have results coming out in 2 tabs. They're population results, they're financial results, so that you can see for any particular run what the results of your particular scenario that you've run are. And just very briefly, the significance of this model is, and I've done the research, it is the first agent-based model addressing this problem of cesarean delivery anywhere in the world. It is a health policy lab, so it's going to permit stakeholders to do their experiments in silico rather than doing them in live. And it's game-oriented, so it's a simulation-based learning environment. What we've learned is that stakeholders like this. They like it very much. They have said that they definitely want to form the coalitions. We're doing that now with them, and they definitely want to take this approach with AnyLogic. We've learned that provider payment reform alone will not work, that you need a multifaceted strategy. And if retooling the workforce is part of your strategy, we know that that will take a lot of time. So very quick overview of what we've done, and I wonder, are there any quick questions? Yes?
How many learning sessions have you done so far?
We've presented this is very interesting, to Washington, the state of Washington. In 2009, the state of Washington put together a similar In 2009, the state of Washington put together a similar coalition. And what they came up with was one intervention that utterly failed, and they spent 2 years with this coalition doing this. So we've started building that coalition. We've had preliminary meetings with them. Toward the end of the year, we'll have our first game playing session with them. Questions?
I had 2 questions, so I'm cheating. The first one is, it looks like you're really trying to drive the rate of cesarean delivery down. And how do you protect against type 2 errors where you drive it down where it shouldn't be? You drive it down too low, or at least in that specific instance.
My glib answer to that is, we'll worry about that if we ever drive it down at all. But it's a very serious question, and it gets to the question of when are cesareans appropriate and when are they not. And we're having to be very careful about that, because it's not that obstetricians are all wrong about this. There are other factors at play. For example, women are not as healthy as they used to be, especially in big cities, and many other factors at play. So I guess the short answer is we're being very cognizant of that and very careful about that.
And then the second question, you had an example where you showed a bunch of women traveling 20 miles to get to a certain place.
Yeah.
So were you able to find sort of like shining cities or the examples of hospitals or obstetricians that you would say, you know, somehow these folks are doing something right? What did you find?
Yeah, actually, in Washington State, for example, where we've come furthest along with this, there is one hospital in the state that has extreme, 12% is their rate. And I visited them. Lo and behold, what they do is they first send the pregnant women to midwives, just like the Netherlands. And then the midwives decide what happens next.
Thank you, Doctor.